The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone, and thank you for joining today's Advances in Autism Research and Care webinar entitled AARC Research Updates. Now before we get started, I want to review a few housekeeping items and let you know how you can participate in today's event. We're looking at an example of the GoToWebinar attendee interface, which is made up of two parts. The viewer window on the left, which allows you to see everything the presenter will share on their screen, and the control panel at the right. Within that control panel is how you can participate in today's event. So let's look at that. By clicking the orange arrow, you can open and close your control panel. The audio pane provides audio information. Please ensure you have chosen telephone audio and dial in. Once you choose a telephone, dial-in information will be displayed, including an audio pin. If you would like to ask any questions of today's presenters, you must enter your audio pin in order to have your line unmuted. At the end of the presentation, you have the ability to send questions to our staff through the questions pane. Simply type in your question and click send. You can also indicate that you have a question and would like your line unmuted by raising your hand. We will address Q&A at the end of today's session. And as a final reminder, today's webinar is being recorded, and everyone will receive an email with a link to view a recording of today's event. Today our presenter is Dr. Allison Hill. Thank you for joining us. Dr. Hill?
Thank you, Jessie. So today I'm going to be talking about some of the research that I've been working on with my colleagues here at OHSU, Drs. Eric von Bahn and Katie Zuckerman. And we've been working on a project about overweight and obesity in children with autism. In this study, we're looking at the prevalence, correlates, and predictors of weight changes over time using data from the Autism Treatment Network database. So next slide, please. Thank you. Overweight and obesity, we know, are increasingly prevalent in children and adolescents. In the most recent nationally representative data set from the National Health and Nutrition Examination Survey, estimates for overweight or obese in kids ages 2 to 19 were 31.8%, and 16.9% of kids in that same age range were classified as obese. So this is a large increase really over the past 25 years in the rates of overweight and obesity in childhood and adolescence. And we know that there's numerous associated health risks with overweight and obesity in childhood, and these include increased risks for sleep-disordered breathing, asthma, orthopedic problems, and type 2 diabetes and hypertension. So next slide. So there's been some suggestions recently that children with autism may be at elevated risk for obesity. And this could be due to a number of different factors, such as atypical eating patterns and food selectivity, which may be common among children with autism. In addition, many kids with autism are on prescription medications that have weight gain as a known side effect, in particular selective serotonin reuptake inhibitors and atypical neuroleptics. These kids may also have decreased opportunities for physical activities that might be more social in nature. As well, cognitive or adaptive functioning impairments could also inhibit their physical activity levels. For example, if a child has motor coordination difficulties, that might preclude them from engaging in some team sports. In addition, many kids with autism have comorbid sleep or emotional problems, which we know are associated with increased weight gain in children in the general population. And finally, there might be some genetic risks for obesity for children with autism. For example, microdeletions at the 11p14 and 16p11 loci are associated both with increased risk for autism as well as increased risk for obesity. However, the question of whether obesity prevalence is actually higher in kids with autism has really not yet been answered by previous research. Many of the previous studies that have looked at this question have been limited by having very small sample sizes or have relied on parent-reported autism diagnosis or parent-reported height or weight data, which can limit the strength of their conclusions. Next slide. So in this study, we looked at overweight and obesity in children enrolled in the Autism Treatment Network database. And so what we did was we took kids at their first visit, visit number 1, so it's a cross-sectional sample, across all the sites that were available. And we took the children who had existing age, gender, height, and weight data. And so that was in order to calculate their BMI. So what we ended up with was about 4,800 kids in our current sample. There was 84% male, and the mean age was 6.2 years. So if you're familiar with the ATN database, you know that it skews a little bit towards the younger side of the 2 to 17 age range. Next slide. So the weight and height data are measured during the physical examination from the ATN visit. They're measured by trained clinical staff using a scale and a wall-mounted stadiometer. So these numbers, in addition to the child's age and gender, are used to convert their BMI into BMI percentiles based on the Centers for Disease Control growth chart. And so what I've listed in the table on the bottom is the cutoffs that are used for the CDC for the BMI for age percentiles for classifying children at healthy weight, overweight, and obese. But one thing to note is that there is a cutoff also for children who are underweight, and we had approximately 237 kids who met criteria for underweight. These children we excluded from group comparisons because we thought there might be additional factors that might be associated with underweight status that may be very different from overweight and obese. And we also did include them, though, in the denominator for prevalence estimates. So on this next slide here, those children are included in the denominator. So these were our initial results showing the prevalence of obesity by sex and age, and the bars are 95% confidence intervals. So there was no main effect of gender, but I did break it down by boys and girls so you could see. And one thing to note is that this confidence intervals are obviously much wider for the girls, and that's because of the smaller sample sizes there. So there's a little bit more error associated with those prevalence estimates. So no main effect of gender. There was a main effect of age, so you can see that really clearly on the far left cluster of bars. You can see that by 12 to 17 years of age, over 1 in 4 kids with autism were meeting criteria for obesity. And it's important to note that this graph does not include the children who are overweight. So this is children who are just meeting that BMI for age percentile criteria of greater than or equal to the 95th percentile. So this doesn't include the kids who are between the 85th and 95th, which is what classifies them as overweight. And we're in the process right now of finishing up analyses comparing these numbers, our prevalence estimates from the ATN database, to a sample from the National Health and Nutrition Examination Survey, which is the best nationally representative sample through the CDC for U.S. Overweight and obesity prevalence estimates. So look for that in some upcoming research coming out of our group. We're just finishing up those analyses now. Next slide. And we also looked at correlates of obesity in this sample. We found that children who were obese were more likely to be Hispanic and Latino. 15.2% of children who met criteria for obesity were Hispanic or Latino versus 8.6% of the healthy weight children with autism. They were also more likely to be prescribed medications. So 31.7% of the children who were obese were on prescription medications, and that's just 1 or more prescribed medications, versus 26.5% in the healthy weight group. Obese children were also more likely to have difficulties with adaptive functioning as measured by the Vineland Adaptive Behavior Scales, the Adaptive Behavior Composite. And obese children with autism were also more likely to experience more severe comorbid problems, including sleep difficulties, affective problems, and anxiety problems, with the latter two derived from the Child Behavior Checklist. But obesity was not associated with gender, cognitive functioning, or with ASD severity based on the Autism Diagnostic Observation Schedule Calibrated Severity Score.
In autism, I'm talking about toilet training in autism.
How do you get so that
Oh,
they can
okay.
hear you?
And next slide. So in conclusion, we found that kids with autism in the ATN database may be at elevated risk for obesity. We're finishing up those comparisons with the NHANES database right now. And this risk for obesity in children with autism may be higher for those kids who have more comorbid problems. So that is maybe sleep, affective problems, and anxiety problems may be associated with increased risk for obesity in this population. But there's a few things that we're lacking in this study. We have no data to inform us about the possible causes for weight gain or overweight or obesity in children with autism. So really one of the big questions is, what is the source of this elevated risk? I had started off this talk by listing out a number of factors that might be associated with increased weight status in this population of kids, but we don't really know what is the source and how many of those might impact weight gain in kids with autism. And we also don't have data on possible mediators of high BMI, and that includes measures of activity, diet, et cetera. We're lacking all of that data. And these are really needed to advance this research to better understand what's going on. Next slide, please. So our future directions are to conduct longitudinal analyses, which we're working on right now, to look at trajectories of weight gain or lack of weight gain over time. So we're hoping to be able to look at some of the factors that might be associated with kids who have more than one data point of BMI data, and look at the factors that are associated with increases in BMI over time, or maybe factors that are associated with healthy weight maintenance over time. And we're really interested in looking into what factors might be modifiable and could be used to guide intervention and prevention efforts in these kids. And that's kind of one of the things that might be interesting about some of the comorbid problems that we found to be correlated in the cross-sectional data that I just discussed. It may be that, you know, certain modifications to sleep or affective or their anxiety problems may be able to have an effect on their weight gain. And what are the long-term outcomes of obesity in children and adolescents into adulthood and those with ASD? And so this is really a hot topic at MFAR in terms of talking about the long-term outcomes for adults with autism. And we really don't know what are the long-term outcomes of obesity in this population into adulthood. We know the long-term outcomes of obesity in the general population, but it's really not clear how these factors might shift and change over time as they gain more independence. And I think that's it for me.
If you have any questions, feel free to raise your hand. If not, we can wait until the end of the presentation. We actually have two presenters this afternoon, and the second is Dr. Daniel Mruzek. If you can just give me one moment, and I will pull up your slides.
Hello, this is Dr. Dan Mruzek, and I'll just check to see if people can hear me. Any kind of feedback appreciated? Hello, this is Dr. Dan Mruzek, and can you hear me?
Doctor, they can hear you.
Great, okay, thank you so much. And should I just go ahead?
Yes, please.
And I will. Hi, yeah, thank you very much. I appreciate it. Dr. Dan Mruzek from the University of Rochester in upstate New York, though I'm calling you today from a hotel in Orlando. I just walked in about 2 minutes ago and got set up and ready to go, so I'm so glad this worked. And I'll just spend just a few minutes with you giving you a brief update regarding our current project. It's a moisture pager, and a corresponding manualized intervention to help children with autism toilet train. Next slide, please. And this is direct from the ATN application. You see the objective there is to conduct a pilot test of standardized toilet training protocol, one that we developed. It involves the use of a novel wireless moisture alarm and a step-by-step manual. We have two manuals, actually, one for clinicians and one for parents, and they're broken out according to modules, and the modules relate to one another in a point-by-point correspondence. There you see the aims below: develop measures and resources for a large N study, evaluate the extent to which the study protocols were completed as intended, that is, look at things like rate of recruitment, retention, fidelity of intervention, fidelity of parents' participation, the number of therapy sessions we're able to complete, and outcome evaluations. And then finally, because we're looking at a fairly large number, well, as you'll see, we have 32 families enrolled, we should be able to look at trends in children's acquisition of toileting skills across two groups. That is the experimental group, the group that has the moisture pager intervention, and then a control group, as you see, a group that receives intervention using the ATN toolkit for toilet training. Next slide, please. Thank you. And just very briefly, I won't spend a great deal of time on this, but I thought it was worth pointing out that a couple of my Len Fellows and I this year, we looked at age at toileting acquisition in children with autism using our local ATN data sample. And just very quickly, if you look along the horizontal axis, you can look at 50 months and then plot up there. You see about 60% of children are toilet trained. That is children with autism. So we're looking at a sizable number that are not toilet trained, even by 5 years old, probably something around the order of 35%. So just in passing, I want to point out that, intuitively we know that toilet training is very important, but then looking at the data, you get a sense that this might help a nice number of families as well. 5-year-olds, perhaps about 35% are not toilet trained in our sample from Rochester. Next slide, please. And here's the project timeline. I began looking at the use of moisture alarms in my clinical practice for difficult-to-train cases. And then I began working with a biomedical engineer, my research partner, Steve McAlevey. He's a professor of biomedical engineering at the University of Rochester. His senior students put together a nice little device that I could pilot out. We got a grant through the Clinical and Translational Science Institute. Through that grant, we were able to develop a more innovative device and pilot that out using single subject research. Got another grant through Innovocracy. This is all small N work up through the grant through the Autism Treatment Network, and that's what I'll share with you a little bit today. And Steve and I and colleagues from Ohio State and Vanderbilt, we just applied for an R40. So just again, just to give you a brief timeline on where we're at. Today I'll talk to you about what's in blue there, the ATN. Next slide, please. Thank you. And again, not to get bogged down at any particular spot, but I'll just point out to you that in one of our early pilot studies, you can see the black line there in James and Laura. That's that black line designates across school days the acquisition of toileting skills using a moisture pager. Those little gray bars, if you can see those are actually toileting accidents. And you can see as toilet acquisition drives up for James and Laura that the toileting accidents drive down. James, just by point of reference, was 15 years old. Laura was 11. Andrew, now he's an interesting fellow, a young man not with autism but rather with Down syndrome. And you can see I did not successfully toilet train him. That's on me. I didn't successfully toilet train him. I will point out, though, that at the end of the school year, we discontinued the study, and he toilet trained within 2 weeks following the end of the school year. Not with the alarm, but following use of the alarm for a portion of the school year. So we may have had some positive effect in Andrew's skill acquisition. Next slide, please. That brings us up to what we're doing now. Like I say, I wanted to share with you our current ATN project. Next time I come online, I can give you the results. The results are due at the end of July, and so I don't quite have those to share with you today, but I can set us up for that. We set out to get an N of 30 participants, children with autism who do not yet use the toilet independently. We actually enrolled 33. We did that because we noticed that we were having dropout. You can see across the study, we've had 7 drop out for a rate of 21%. So we were able to replace 3 of those families. So we have a total of 33 enrolled at some point in the study anyway. And I have notes here that suggest that recruitment has proceeded reasonably well, though the dropout rate is somewhat high. I'm grateful that we have some nice diversity in our sample of families between Rochester and our 2 partner sites, Eric Booter's group at Ohio State, or nationwide should I say, and Vanderbilt as well, with Whitney Loring heading up recruitment and the study in Vanderbilt. Between the 3 sites we have nice diversity. And one thing we found is we had to make an adjustment to the original criteria regarding history of toileting, because what we found with children with autism is that many of them had some history of using the toilet for urination, but they didn't have a regular history. So I set out with this notion that we'd get a group of kids who had never used the toilet, you can imagine, or very rarely used the toilet, let's say. But what we really found in our recruitment process was that we found a lot of children who on rare occasion used the bathroom, though they typically did not, or they did regularly for 3 weeks and then stopped, that kind of thing. A little bit of that idiosyncratic behavior profile that you can sometimes pick up with children with autism seemed to play out in our experience with the children with autism. Okay, next slide, please. So we've developed an innovative method designed to meet the goals that entails the use of a wireless moisture pager, and we've configured it to interface with an iPod using Bluetooth technology. We call this the Quick Trainer app, or QT app, and like I mentioned to you before, it has a corresponding manualized intervention. Next slide, please. There it is. We didn't invent the Apple product, of course, but I have a picture of it there anyway. But you can see the transmitter and then the disposable sensor that gets placed in the child's underwear. Next slide, please. And what happens is actually one more slide I'll show you in just a second. That transmitter snaps to the disposable sensor. So it's an iPod with Bluetooth technology. It has a range of approximately 30 feet. Capabilities of the app include time-stamped accident data, emailing of success or problems. So every accident that the child has gets recorded and can be sent to us immediately so that we can check from the comfort of our office about a child's progress. Likewise, a parent can indicate to us that the child's been successful by pushing a button. And also, right on the app, we can individualize the reinforcement menu that the child has at their disposal for getting urine in the toilet bowl. And so you can imagine there's a little iconic representation of their favorites, whether it be Skittles or Blue's Clues, etc., and they can point immediately as to what they want. That's in case of not getting tangible reinforcement while they're still on the toilet, you know, because it's all about timing often. And we've got ideas with regard to next step modifications, including a graphing function, and what I'd like to add also is a dry pants check reminder. So every once in a while that might clue the parent in that it would be a good time just to check with the child, indicate they can check to confirm that the child's dry, and then they can praise or otherwise reinforce the child's self-management behavior, kind of a dry pants check reminder. So we have these ideas in mind coming up. Next slide. This is what I wanted to show you a moment ago. You can see here how the transmitter snaps onto the disposable sensors. We created these disposable sensors rather cheaply. What we did is we used some of our funds to hire part-time undergraduates, and we bought a sewing machine, frankly. And we put 2 threads through these sanitary pads, and when those threads are lined up nicely and some urine connects the threads, if you know what I mean, it emits an immediate signal to the pager and lets the child and or parent know that they're having an accident. Next slide, please. Thank you. And you can see how you see there in that pair of underwear how the disposable sensor fits inside a child's underwear. And then you see the little app on the iPod. That's essentially the system there. That's our technology in a nutshell. Next slide, please. There's a nice face shot of the iPod. You can see there's an alert there. Somebody's on alert. That is, they're having an accident. This can be available to the child. You could Velcro it to their shoulder if you care to, so it's that immediate. Or you could set it on the desk near the child, or a parent could carry it around with them. For example, if somebody was working in the kitchen, their child's in the next room, they would know immediately. They could go in and interrupt the child. not startle them, but surprise them a little bit and say, this is your big moment, and then hustle them off to the bathroom. Next slide, please. There's the manuals, at least handsome screenshots, if I do say so myself. And in the interest of time, I can't walk you through the manuals. I won't even try. But you can read these notes at your leisure. Step-by-step planning guide. We developed these as part of the ATN study. My study interventionists, they've done a fantastic job, in my humble opinion. I in-service them at the start of the study, and we've had weekly interventionist calls to keep up to date. We've had very few difficulties or the kinds of concerns that set the occasion for an adverse event. Thankfully, we've had extremely few of those throughout the duration of the study. It's run very smoothly in that regard. Next slide, please. And some folks, they wonder, and this is a very good question, you know, if the child's already having an accident, isn't the opportunity to learn how to use the toilet, isn't that opportunity already passed? And without walking you through this slide verbatim, I'll just share with you what I think typically happens for the successful child. The child's not demonstrating at the start of research any precursor behaviors, typically. So they're just having their accident, emptying their bladder amid their busy day, just during their busy day, I should say. And the parent interrupts that flow, hustles them to the bathroom. If a little urine gets in the toilet bowl, reinforcements dosed immediately. Across subsequent days, what we often find is that the child begins to demonstrate what behavior analysts call precursor behaviors, and what we might, the rest of us might know as the potty dance or other signs of a full bladder. They start to grab themselves or pace or vocalize or these kinds of things. But by and large, it's things that parents can recognize. And then they can begin taking them to the toilet even prior to the onset of the page. And through that process, the page begins to drop out of that chain of events while the child's independent use of the toilet begins to drive up. Of course, with the parent prompting initially, but then later on with greater independence. So I won't read this slide verbatim in the interest of time, but you can refer to that if you want to get a little greater depth of detail with regard to the procedure. I call it the 5-minute procedure, by the way, because one of the things I do is I encourage my interventionists not to have the child sit on the toilet for longer than 5 minutes per trip. I figure if they're not going to urinate within 5 minutes, reset things, thank the child for trying, and just be ready to hustle them back in a little while. Okay, next slide, please. All right, so a little bit more about the study itself. We have a control condition, as I alluded to earlier. We call it the standard behavioral intervention for purposes of the study. We have random assignment into this group, the control condition, or into the moisture pager group, of course. We control for an equal number of visits. That is a parent training, an initial parent training, I should say, plus 4 brief booster shots. They're usually a psychologist hour of about 50 minutes, 50 minutes. And you can see that's simply the ATN toolkit. I just took a shot with my iPhone while it was sitting on my desk the other day just to prompt us. You've seen this before, but for the control group, they're simply training up the control participants, that is the parents, on how to toilet train using the ATN toolkit. And it's worked very nicely. It's really been a nice control procedure, I think, for our purposes because it's packed with good information. But if you know what I mean, it's the kind of information that's part of a standard toilet training protocol. So it's been a real nice match for us in that regard. Next slide, please. Key measures that have been developed as part of this current study. Well, we had to put it all together, and we had 1 year to do it, so we really went to work. I'm pleased with how things turned out. We developed a readiness checklist so that we could screen. We didn't want children to enroll in the study if they were nowhere near toilet training readiness, because we were only toilet training for 3 months, and so we didn't want to have children who weren't ready to sit on the toilet at all or something like that. So we developed a toilet training readiness checklist, a parent satisfaction survey. I really like the toileting data log that we put together. We thought long and hard about how we were going to have parents record data for us in the context of the home. What we landed on is having them record a data log for the 3 days prior to the booster session. So they're not keeping data every day in a diary, but rather just for 3 days prior. And if you can imagine, it's broken up into 3 sections. So it's accidents, check marks, successes, check marks, and then an overall global rating scale of progress. And so we have three indices of progress there. And if you recall, like I shared with you at the top of the hour, we also have the data coming in from the iPod. But of course, we don't have that for the control group. But for the experimental group, we also have iPod data, the timestamp data regarding accidents, for example, that we can also use as backup data as well. Then we also developed a fidelity checklist for both groups, an adverse event tracking sheet. We modified an existing parent expectancy scale so we can have a sense of whether or not parents' expectations for success serve as moderator variables in the study, and then fidelity checklists for both the interventions. So at the conclusion of the ATN study here, we've got everything we need essentially for a larger N study in toilet training. Plus, through the pilot study, the other thing we've been able to do is make all sorts of minor tweakings to these documents. So next time around, they should really be smooth. And so for that, we're very pleased. Okay, next slide, please. So where are we headed with this? What's our next steps? Well, our next steps is, like I said at the top of the hour, we'll have soon the data. We're just now getting it loaded up for analysis. The ATN group and colleagues, study tracks, et cetera, they've really been very helpful. They've been great for us to work with in terms of getting the data loaded up. I'm grateful to them. And we'll be able to analyze that. Next time I'm on a call like this, I can give you the results. That's really the thrilling part, I'm sure. And but after that, we have applied. Steve McAlevey, the biomedical engineer, and I, we just recently applied for something at the University of Rochester through a group called UR Ventures. That's our tech transfer office, and they have a $60,000 grant to improve technology that improves quality of life for individuals, and this certainly should foot that bill. And so we just applied for that, and we got into the final running with that. We just presented. It was a bit like Shark Tank last 2 Fridays ago, and that looked well, and I think we might get that. So we have a next step there. Next slide, please. Thank you. And then my colleagues, both Whitney Loring at Vanderbilt and Eric Buter at Nationwide in Columbus, Steve McAlevey, my colleague at U of R, and myself, we just completed the application for an R40. The R40 we're calling our Train the Trainer study, and what we'd like to do is train classroom teachers on how to implement the procedure with their students. And the next iteration of the Quick Trainer is going to have multiple channels. So if you can imagine, a teacher could train 2 or 3 students simultaneously in her or his classroom using the device. And so we're working through that right now. That UR Ventures grant could come in very handy for putting that together. Okay, and just a very brief mention here. I think we're probably right there, and so I'll let us go at this, but I'll just mention there's probably other populations that this device can be useful for as well. So we're really excited about possibilities, assuming that it's more useful than standard behavioral intervention, and that's a question of science that waits to be answered. Next slide, please. Okay, and I want to thank all of you for your graciousness today and the opportunity to present these preliminary data, if you will, or at least the information leading up to data. And you see a number of colleagues whom I'm very impressed with, having worked with them for the last year at the 3 sites. They've just done a fantastic job helping me with this study. And I hope everybody has a great day today. And I'll look forward to seeing you all soon. Thank you very much.
Okay, great. Now, if anyone has any questions, please raise your hand or just feel free to type that directly in. I'll give you a minute.
Let's see here. Where do I go for that?
Okay. Alrighty, everyone. Well, it seems like we've reached the end of our webinar, and I'd just like to thank Dr. Hill and Dr. Mruzek for their presentations, and have a wonderful evening.
Thank you very much. I appreciate it. Have a good day.
Bye.
Thank you.